Hi, this is Brian Kim. I'm going to share with you case number 18 in the best way to do cataract surgery series. This is a small pupil, and I'm going to show mechanical fracturing and how I do it safely without worrying about snagging the capsular bag. And then there's also a stuck haptic, and I'll show you how I'm able to release that stuck haptic from the optic. I use a corneal marker to help me center and size my rhexis. I make my two paracenteses incisions. I inject intracameral lidocaine and epinephrine, and you can see I'm gently and slowly going on top of the iris and also under the iris, very gently, gentle pulses to help make sure that epinephrine gets all the way around. I inject my dispersive viscoelastic into the anterior chamber, and then I do my triplanar corneal incision. I make a vertical groove and then tunnel and then enter the anterior chamber. I use my puncture style capsular rhexis. I make a puncture, pull down, and then sweep a little bit to the right to create a little bit of a flap. Once I get that edge, I grab the edge of the flap and I start going around circumferentially. I'm following the corneal marks, which are going to help me center and size my capsular rhexis. I'm grabbing at the edge and going around as I go. I'm making sure I am not putting any pressure on the wound to minimize any viscoelastic egress, which can cause my rhexis to radialize. I burp some viscoelastic at the end to decompress the anterior chamber. I do my capsular fornix hydrodissection technique. I place the cannula out to the contralateral equator flat, and then I get into the capsular fornix, rotate the cannula tip down 90 degrees, and then I push the BSS and it flows. A nice hydrodissection wave propagates very nicely. I decompress on the left, and then I start to spin the lens on the right, and this happens very smoothly. I lift my incision with my chopper and then go into the eye with irrigation off to minimize Descemet's trauma. I remove the surface epinuclear material and then begin the double chop technique. I place the chopper out to the contralateral equator, and then I rotate my phaco-tip vertically, and I go subincisionally, and I stab the lens, and then I bring both instruments together, crushing the girth of the lens. Again, this is a very safe technique and zonular friendly because all the forces are oriented towards the center. I'm able to chop the lens very efficiently. I place the chopper out across the right heminucleus into the capsular fornix, pull the chopper centrally towards the phaco-tip, and then I crush and chop the right heminucleus. This is the cross-chop maneuver. I then begin successive mechanical fracturing forces, placing the chopper out to the equator, sandwiching the lens pieces between the chopper and the phaco-tip. Oftentimes, I'm placing the phaco-tip fairly deep into the capsular bag. I'm doing this without any phaco or vacuum in order to minimize any trauma or risk to the capsule. Once the lens pieces are liberated, I begin crushing and removing the lens pieces using intermittent bursts of ultrasonic energy, as well as using high vacuum. I'm very careful to make sure I'm crushing and sandwiching the lens pieces. Again, I'm going under the epinuclear shell. So again, I remove the surface epinuclear material at the beginning of the case. I make sure I'm under that epinuclear level. I slide out the chopper out into the capsular fornix, and then I place that phaco-tip deep, and then I'm able to crush the lens pieces. So the key is to make sure I'm underneath the epinuclear shell. And you know this because after I remove all the lens pieces, well, I often have a very robust epinuclear shell, especially on these cases, not talking about the very dense lenses. Because I have a robust epinuclear shell, that means I am always underneath the epinucleus when I'm doing my chop techniques. So even with these small pupils where you're worried about where is my chopper, where is it? Am I over the anterior capsule, under? Am I going to rip the zonules? You will never rip the zonules because after you remove the surface epinuclear material, you can see that little step off into the periphery. You just slide the chopper out underneath that little step off, and you're gliding over the endonucleus, but you're underneath the epinucleus. You're able to slide out, get into the capsular fornix, and then perform the chop maneuver. So at this point, I have only a few little fragments left. I'm using mechanical forces to crush the lens pieces into bite-sized pieces before I emulsify the lens pieces. And now I'm left with the epinuclear shell. I'm just grabbing the anterior portion of the epinuclear material, and it just prolapses out of the bag. And this is the end of the lens removal. After I'm done with the chop maneuver, I push BSS through the paracentesis. I pull out the phaco-tip, switch to the INA in order to maintain chamber stability, and then I begin my INA. I start subincisionally, removing all the cortical material, and I switch to a polish mode in order to remove any lens epithelial cells and also to polish underneath the anterior capsule as well as on the posterior capsule. And the polish mode really provides excellent safety, being able to place that tip out even though I can't visualize it. I'm pushing BSS through my paracentesis. I'm pulsing BSS into the subincisional capsular fornix to look for any dust bunnies. I inject some cohesive viscoelastic, and then I sweep to the left side and then to the right side. Again, I'm trying to smoothen out and remove any potential lens epithelial cells. These lens epithelial cells can cause capsule contraction over time. And so I'm sweeping first to the left and then to the right. And then now I'm injecting my single piece acrylic intraocular lens into the capsular bag. You can see here that as I deliver this lens, the haptic is actually stuck to the optic. And so you can see this trailing haptic is actually stuck to the optic. I'm going to go first, I'm going to try to tease that haptic off the optic using the INA. Actually, both haptics are actually stuck to the optic here. I'm able to release the trailing haptic off the optic by using the INA handpiece, but I'm not able to do that for the leading haptic. I'm pushing and pushing. There's no reason to get frustrated. You don't want to cause any traction or stress on the zonules. So what you want to do is a two-handed technique, and I just use my BSS cannula. And as I stabilize the optic with the INA handpiece, I use the cannula to tease off and push the haptic off, and you can see that released very nicely. I go underneath the lens to remove any viscoelastic from within the bag, and then I remove the viscoelastic from the anterior chamber. I'm pushing BSS in order to pulse into the angle in order to make sure that there's no viscoelastic. And then I remove the INA handpiece, but pushing BSS to stabilize the anterior chamber, and then I hydrate my incision. So again, this is a small pupil. I'm making sure always that I'm under the epinuclear material every time I place the chopper out to the equator. By doing so, you're never outside of the capsular bag, and you won't traumatize the capsular bag or the zonules. And you can see, as proof of my technique, in these cases, when they're not hypermature, I almost always have an epinuclear shell, and that is proof that I'm, again, within the capsular bag, within the epinuclear shell, crushing and removing the lenses with mechanical fracturing forces. Lastly, you saw that I used a two-handed technique using the cannula to free the haptic off the optic. So whenever the haptic is stuck, you can try a one-handed maneuver, but when needed, using a two-handed maneuver is a much more controlled and effective way to release the stubborn haptic off the optic. So I hope this was helpful to you, and thank you for your attention.